Okay, hello. This is the respiratory exam, OSCE, for the Warwick Clinical Skills Society doodah in November. So we're going to begin, as we always do in these big exams. We wipe, then we do our generals, and then we do IPA, inspection, palpation, percussion, and auscultation. So wipe is the usual: wash your hands, introduce yourself, check the patient's details, two-factor authentication, trust dependent. Then explain the examination, gaining informed consent. We talked about in the abdo exam video and lecture that you can't gain consent before you've explained the procedure, so that's the flaw in how most people interpret wipe. And then position the patient appropriately, and about 45 degrees should serve you well in this one. So general exam, you're going to stop, end of bed inspection, you're going to have a look, and you're going to have a listen at the end of the bed. You're looking for patient's age. Now, age because of recurrent chest infections in the young and asthma, versus older patients are going to have interstitial lung disease, pulmonary fibrosis, occupational things, and COPD. So this is an age-related tool that you can use for diagnosis. Now, medical paraphernalia, how are they for mobilization? Have they got any lines in that will make mobility and examining harder? Are they obviously cachexic? Do they have any sputum pots? If so, what colour is the sputum? Consistency, quantity? That should have been picked up in the history anyway. You're looking for any tissues or napkins, handkerchiefs, things with a similar thing going on there. Any inhalers and the like. Are they visibly short of breath? Are they blue? Are they cyanotic? What's their level of consciousness? Just looking at them. Are they using accessory muscles? Are they having difficulty breathing with recessions of the intercostal muscles? Are they tripoding? So this is the position the patient will go in to make it easier for those accessory muscles to help them breathe. Sort of like when you lean over and like put your hands on your thighs after you've run for a bus kind of thing and you've missed it. When you're listening, listen out for a productive versus a dry cough. Okay, productive coughs, they're bringing something up. It's called expectoration when they bring something up. So what colour is that? So you need to run a differential on the colour of the sputum they're bringing up, because that's more infective. It could be COPD with an infective exacerbation of symptoms, or it could be your bog standard respiratory tract infection on its own, bronchiectasis maybe. What about a dry cough? Well, a dry cough is more indicative of asthma, or it could be more indicative of an early infection going on there, things like that. You also need to be aware of cystic fibrosis, both for age and for the productivity of cough. And then this concept of wheeze or stridor. So wheeze and stridor are sort of a high-pitched noise, but they're named differently because they sound a little bit different based on where they are anatomically. Your upper respiratory tract ends at the glottis. There are a few definitions. Let's say it ends at the larynx. Stridor is at the very top, as if you've strode from the lungs up into the upper respiratory system. You stride up. Okay? A wheeze is hearing that high-pitched noise down below. I use Aragon, so Strider from the Lord of the Rings film, to think he's striding away, because Aragorn was like a ranger who roamed around. If that works for you, it works for you. Now, your general exam, you're going to start with the hands, then go up to the head, the neck, and then the chest. So the hands, we're going to look at the different surfaces. So we'll split the symptoms up based on the surfaces. So start looking, whichever way you want, but I start with this dorsal aspect. So can I see your hands? Hold them out for me like this. And I'm looking for a couple of things. I'm looking for cyanosis, so that's respiratory conditions in general. You're blue if you're not perfusing because you've not got enough oxygen carrying capacity. Rheumatoid nodules and autoimmune signs in the hands because they risk effusions. So extra-articular meaning joints, extra-articular manifestations of rheumatoid and other autoimmunes include effusions, so pleural effusions. And they can also cause fibrosis, scarring of the lung tissue. Skin thinning and bruising, because that's a risk of glucocorticoid steroids, which are often prescribed in asthma and other flare-ups of these conditions. So if they've been on them for a while, this might be an iatrogenic cause that you're seeing in the hand. And then CO2 retention will give you a flap of the hands, or a fine tremor might be from salbutamol use, particularly if they're, puffing a massive salbutamol nebulizer at the side of the bed because they've just had, an infective flare-up of their asthma or what have you. Flip the hand over after you've had them do the hands out and you've seen them shake or not. And you're looking at the palmar side now in the anatomical position. It's the anterior side. Temperature and skin appearance for, again, respiratory things. You're going to take the pulse at the radial there for rate and rhythm. And whilst you're doing that, surreptitiously do it for 30 seconds and then look at their chest and look to see how it's moving. Because we change our respiratory rate very consciously when someone says, I'm just going to count your breathing rate. Okay? We want it to remain subconscious. So, we'll move to the face. So we're looking for pallor of the conjunctiva, indicative of anemia, so that's a poor oxygen carrying capacity. Horner's syndrome, so ptosis, anhidrosis, meiosis. This is indicative of Pancoast tumour. I've got a little cartoon coming up for that. And then cyanosis. So the blue in the face at this stage is quite dull. We've already done cyanosis. This is Horner's. So ptosis is a lid droop, which you'll do more in block 3. Meiosis is a small pupil versus this. So there'll be asymmetry of the pupils here. And then anhidrosis, an means an absence, hydrosis means sweating. Okay, so they're not sweating on one side of the face. That's Horner's syndrome, and that's, for example, a Pancoast tumour. The sympathetic chain has been compressed in the neck, and the ipsilateral sympathetic function isn't working. So you need the sympathetics to open the eye, you need the sympathetics to dilate the pupils and to sweat. Don't worry if you can't quite figure that out yet. That's more of a block 3 and 4 thing, but there's overlap. And you do one big phase 1 exam, so it's worth knowing. So, the general exam, so you're going to do JVP. So between the two heads of sternocleidomastoid, there's one that goes to the clavicle, there's one that goes to the manubrium here. So between the two heads is a little triangular gap, and in that gap you can see this massive as vein here, the internal jugular vein. So you're going to measure this internal jugular vein. We also do this in the general exam and in the cardio exam. So I'm not going to go into the machinations of how to do it there. But if it is raised without the hepatojugular reflex, or with it anyway, you're thinking right-sided heart failure, because the heart can't receive the caval venous blood that's returning back to the right side of the heart. So blood builds up into that internal jugular vein, and the result will be that you'll have this JVP raised. Do your lymph nodes exactly the same as you did in the general exam. So you're doing all of the ones in the head and in the neck. So the 2 S's for inspection of the thorax are structural changes and scarring. So you're looking for barrel chest, which is obstructive, particularly COPD. You're looking for pectus and pectus carinatum, or pigeon chest, big outpouching of the chest, and pectus excavatum. These can be congenital, or other things can cause them as well. They will affect the ability for the chest to expand and contract, and the ability for breathing. And you're looking for generalized asymmetry, so any traumas going on there, is one side not inflating versus the other side, any ribs that have cracked or things like that. Scars, I'm going to give you 3 sets. So you're thinking about the neck, you're thinking about a midline, and you're thinking about a mid-axillary. So the neck, think about things like carotid accesses, or central lines, cricothyroidotomy scars, or tracheostomies and things. The midline is what we call a thoracostomy, so those could be some old open chest procedures, or it could be open heart surgery, or access to the lungs for different things. Look for any laparoscopic holes bilaterally, and then lift up the arm and have a look in the axilla, because that's where chest drains are inserted in the revised triangle of safety, which you've done your anatomy. And then that animation is just to state that you should always flip the patient over, do the back, so inspect the back for the same things, any scars or swellings. Palpation, we've got acute kitten because the mnemonic is CAT, C-A-T. So you're going to palpate with chest expansion. So you grab the chest either side, you bring your thumbs in with informed consent from the patient, tell them to take a big breath out to keep your thumbs off the chest and the skin held quite tight, and your thumbs will move apart and together, and you're checking for symmetry of that expansion. Whilst you're there, apex beat, which from your surface anatomy you know is midclavicular line, left side, 5th intercostal space. So you're going to feel for any deviation there. And then tracheal deviation, so suprasternal notch, feel for the trach, and then work your way up superiorly. It will deviate away from a pneumothorax or an effusion as air and fluid respectively push the trachea away from the side of issue, but it will deviate towards holes. So a pneumectomy or a lobar collapse. Holes that haven't been filled, it will deviate toward those. So that's worth saying. Percussion. So you're going to percuss bilaterally. So supraclavicular, percuss on one side, then on the other side, and listen for differences. Then infraclavicular, then 3 to 4 down to the costal margin and the axilla. Make sure you're going left, right, left, right, left, right. Practice percussing on all the hard surfaces you possibly can and on other people with informed consent. Then flip the patient over, and the examiner will probably say, move on, because they've seen them do it on both sides 100 times that day, they don't care. Would you like me to repeat on the back? Please don't. So, 4 sounds now that you're listening for with percussion. Hyperresonance, which is indicative of a pneumothorax because it's just conducting through air, or there should be something attenuating the sound. Resonant, which is normal. A dull sound, which is fluid or tumour consolidations. And then stony dull, a big pleural effusion. Okay? So the thicker something gets, the duller the sound gets. Auscultation time now, so you can finally get your stethoscope out. And the good news is, you're going to auscultate in the same regions. So supraclavicular, use the little side, the bell, as opposed to the diaphragm. Supraclavicularly, then make a show of flipping it over to the other side to do infraclavicular, down to the costal margin. Don't forget your mid-axilla. What do? We flip the patient over. Would you like me to do it on the back, examiner? They'll say, please don't, just to save a bit of time. While you are doing it on the back, you get to the lower lobes of the lungs and then assess for sacral edema. So give it a poke, boom, inform the patient you're going to do that. Then assess for pedal edema. You're looking for any kind of pitting edema. That's associated with right ventricular failure. While you're down at the calves, feel for warmth, pain, tenderness, or cramping, indicative of a DVT, a deep vein thrombosis, because the last thing you want to miss on a shorter breath presentation is a pulmonary embolism. Finally, you're going to do vitals, particularly O2 sats, respirate, heart rate, give oxygen therapy if needed, peak flow test for obstructive disease, particularly asthma, chest x-ray if any abnormalities were indicated during your examination, which was the whole point of the exam, and a cardiovascular exam because so often the heart and the lung pathologies affect the other. So there you go. Sources for this talk were MacLeod's, Geeky Medics, which is a fab-free resource, and Vinod Damayanti himself. And that's it. There's a respiratory exam. So have a go at the questions below, and thank you.